Thanks for joining us for our fourth session of the summit, which focuses on women, girls, and those with the potential to menstruate who are affected with inherited bleeding disorders. Despite considerable progress in bleeding disorders research and innovation, disorders affecting women and girls have been vastly underrepresented in research. In fact, many of the bleeding disorders affecting women are difficult to diagnose. Many people who experience bleeding symptoms, particularly heavy menstrual bleeding, go to their gynecologist for care, not even considering the potential for an undiagnosed bleeding disorder and the potential for help from a hematologist. The good news is that there are more opportunities now than ever to have a discussion about the most urgent areas of focus. And we heard clearly from our listening sessions to the community that progress here can go a long way to improve diagnosis, daily management, and long-term health. It's vital that we inform our research priorities by patients and caregivers. To help provide a bit more perspective, Shelly Horowitz will share her experience as a woman with hemophilia. Shelly is a licensed school counselor and school administrator with over 25 years of experience in the field of education. She has strong ties to the bleeding disorders community with 6 traceable generations of hemophilia A in her family. Like many women, Shelly struggled to receive a hemophilia diagnosis, growing up in a time when women were believed to be just carriers. After attending multiple hemophilia conference events and advocacy training sessions, Shelly synthesized information and developed an understanding of how to present information about bleeding issues in a compelling way to medical providers. Working to empower women, Shelly has spoken with local hemophilia chapters and at national conferences, sharing crucial information on partnering with partners for bleeding disorders diagnosis and treatment. Shelly writes a column for Hemophilia News Today, addressing issues regarding women and bleeding disorders called The Forgotten Factor. Our plenary will then look at specific areas where we need greater scientific focus to design the right kinds of new diagnostic and therapeutic strategies. We know that disorders affecting women have unique mechanisms based on the role of estrogen in the body. So we have invited Dr. Wendy Kohrt to speak with us about the bioenergetic and metabolic actions of estrogens. Dr. Kohrt is the Distinguished Professor of Medicine in the Division of Geriatric Medicine and the Nancy Anschutz Chair of Women's Health Research at the University of Colorado Anschutz Medical Campus. She is a recognized expert in metabolic and hormone research, and her work on the role of estrogen in the regulation of numerous biologic functions informs how we think about treatment goals, both short-term and long-term, for women and girls with bleeding disorders. We are looking forward to our discussion today. Let's get started.
My name is Shelly Horowitz, and I have hemophilia A. I am so thankful to the National Hemophilia Foundation for their commitment and dedication to researching bleeding disorders. Like many women who struggle with bleeding issues, it took me many years to receive a proper diagnosis, despite knowing hemophilia is in 6 generations of my family. I was 45. It took a few more years until I accessed treatment that worked for me. Research is so critical and can be life-saving for people who struggle to access care. The specific research on the variant that causes my hemophilia was a major key to understanding and informing my care. I strongly believe I would not have access to the treatment I have today if it weren't for the scientific research that validated my bleeding issues despite my higher factor VIII levels at about 20%. The research showed my variant has a reduced binding to von Willebrand factor, reducing stabilization of factor VIII in the bloodstream and reducing the half-life of the factor VIII that I produce. This is most likely why I was bleeding. Fascinating and also critical. I learned this thanks to a My Life, Our Future report that pointed me to the research, and I shared that research with my provider. As a woman, bleeding issues are likely to be questioned and minimized. Research was key to understanding my bleeding and receiving care. My doctor's knowledge expanded as they read the peer-reviewed medical journal articles on my variant that I provided. Research strengthened my ability to self-advocate when speaking to providers. More important, it validated my experience, and now I have treatment. I am really active, and I was getting bleeds every 3 to 6 weeks. And now I've gone over 5 months without a bleed. It is life-changing. It is my deepest hope that unifying our community with a research focus will assist patients and providers in improving diagnosis and care for all people with bleeding disorders.
Thank you for the invitation to present some of our work on the bioenergetic and metabolic actions of estrogens today. I have no conflicts of interest to disclose. My talk is going to be in 3 sections today. First of all, I want to provide for you a working model for how we view the potential consequences of the loss of gonadal function. And I'll say that I'm going to focus primarily on women today, or female animals. So what I'm really going to be focusing on is the loss of ovarian function. But I will tell you that the loss of testicular function in men and male animals has very similar effects to what I'm going to share with you. After we do that, we're going to go on and talk about the preclinical evidence for bioenergetic and metabolic consequences of the loss of ovarian function. And that's because there isn't a wealth of research that's been done in humans. So I want to set the stage for why we think is important by looking at some of the wealth of evidence that's available from preclinical models. And then finally, we'll go on and talk about the clinical relevance of all of this. So let's start out looking at the model. The loss of gonadal function, because the ovaries and testes are endocrine organs, has the potential to have an impact on other systems, and it could impact systems in a way that might increase disease risk. And the reason we focus primarily on women is because the loss of reproductive function, the aging of the gonadal system, occurs in middle age in women. Average age of menopause is 51, so they live a substantial portion of their lives after having lost the benefit of, or we assume benefits, of the products that are produced by the ovaries. In men, on the other hand, it's questionable as to whether they actually go through a phenomenon that's similar to menopause, sometimes referred to as the andropause. If they do, it happens at a much later age, probably at least 20 years later in men than in women. And if we drill down into this general concept a little bit deeper, we know that there's an exceptionally well-studied example of how the loss of gonadal function can increase risk for a disease. And that is that we know, especially in women, that the loss of ovarian function, and specifically the loss of ovarian estradiol, accelerates bone loss, and that this increases the risk in women for osteoporosis. There's also an age-related loss of bone that occurs, but we know that there is an estrogen-specific loss of bone that happens in virtually all women. But that may not be the only system that's affected by the loss of ovarian function. Other tissues may be affected. There's a lot of controversy regarding how brain function may change in response to the loss of estrogens, perhaps increasing risk for dementias. I'm not going to talk about that today. I will share some evidence for you that the loss of estrogen may influence muscle mass, the loss of which is referred to as sarcopenia. It's also possible that the loss of gonadal function affects the regulation of systems, like the regulation of energy balance or body weight regulation, in a manner that promotes fat gain and as a consequence of that, increased risk for obesity-related diseases like cardiovascular disease and type 2 diabetes. And I will show you evidence that the promotion of fat gain by the loss of estrogen does not just mean that women gain more fat in the same regions that they've accumulated fat to that point in life. There's actually a change in the distribution of fat accumulation, whereby women start to accumulate more fat in the abdominal region. And I'm not going to talk about this today, but it looks like there could also be a shift in the cellular composition of fat, and that adipocytes that come from different progenitors than conventional progenitors may actually have a highly inflammatory profile. And we know that inflammation is an underlying mechanism for many chronic diseases. And then something else I'm going to talk about that is not well appreciated in the clinical research community, but has been demonstrated many times in laboratory animals. And that is that gonadal hormones, and specifically estradiol in females and testosterone in males, has an extremely potent effect to regulate spontaneous physical activity, so that when sex hormone levels go down, animals become much less active. And because we know that there are so many health benefits of being physically active, this decrease in physical activity may exacerbate all of these other processes that increase risk for chronic disease. So that's the working model. That gives you a little bit of an insight into my brain and how I think about these things. And now let's go on and talk about some of the preclinical evidence for what I want to share with you. I picked this study. This is not my work. I picked this study from the literature because it conducted these experiments in both mice and rats. So from our two most common models of preclinical research. And this slide is showing you the changes in body weight in response to either a sham surgery or an ovarectomy where the ovaries are removed. So for the sham surgery, everything is the same as in the ovarectomy, except the ovaries are left in place. So in both mice on the left and rats on the right, you can see that the sham surgery causes a small decrease in body weight, but the animals recover in a few days. In the overectomized animals, you see the effect of surgery, both mice and rats, but then the rate of weight gain accelerates pretty quickly. And by 3 weeks out from the surgery, you can see that both species of animals have much higher body weight levels than the sham-operated animals. And I'm not going to show you a slide of this, but this isn't just because of overeating. These investigators also conducted experiments where they gave both groups of sham and overectomized animals exactly the same amount of food, and the overectomized animals still gained more weight. So maybe it's physical activity, which is what's shown in this slide. This is just locomotor activity as they move around their cages. Again, especially in mice, you can see the effect of surgery, but in the sham-operated animals, they're back to their normal levels of activity in no time. Whereas in the overectomized animals, by about a week and a half after this surgery, the physical activity level, how much they're moving, is decreased by about 30%. And in rats, it looks like they were struggling to maintain their normal locomotion patterns, but by about 2 weeks, they had just given up, and they too showed an activity level that was reduced by about 1/3. This next study, which came out of the University of Minnesota, makes this point even more dramatically. These were mice that were housed in cages that had running wheels. So mice in particular are extremely active. You can see that the sham-operated mice over this roughly 2-month period ran an average of about 5 to 6 miles per day, 8 to 10 kilometers. These other two lines on this graph are two groups of overectomized animals. And you can see that their physical activity levels, their running levels, are dramatically lower than the sham group. They're decreased by 70 to 90%. And in one group of these animals, after 9 weeks after surgery, they were treated with a placebo hormone therapy, so no active hormone provided. And there was no spontaneous recovery of their physical activity. But animals that were treated with estradiol, within a few days or a week, had almost normal levels of physical activity. So a complete rescue of physical activity by just providing back estradiol. And this was some of the first evidence that when you reduce all of the factors produced by the ovary and just add back one of them, estradiol, that's the way we isolate the action of that specific hormone, that demonstrates that it is this hormone that is likely responsible for this phenotype that we observe. In this study, we go beyond just body composition and look at the effects of ovarectomy and the effects of adding back estradiol to isolate again that specific hormone. So we're looking at groups of sham-operated animals, overectomized animals, and overectomized animals treated with estradiol. So here you see the effects on body weight, the increase with overectomy that is completely prevented by estrogen therapy. And if we look at the extent of adiposity measured as percent of body weight, this makes the point very dramatically. The overectomized animals have almost 2.5 times more body fat than the sham-operated animals. And again, that's completely prevented by estradiol. And if we look at energy expenditure, this was measured during the light phase when animals are very sedentary. They don't move very much. So this is considered a good index of resting metabolic rate or basal metabolic rate. You can see that the overectomized animals, even when this is expressed per kilogram or unit of body weight, there is this decrease in resting energy expenditure. So animals tend to become more efficient. They expend less energy to maintain body functions. And again, this is prevented by estradiol treatment. And the final index that I wanted to share with you here is more of a functional one. This is the rate of glucose disposal in response to an insulin stimulus. So this is an index of how insulin resistant animals are, what their risk for diabetes is. And this decrease in response to overectomy indicates greater insulin resistance and risk for type 2 diabetes, and that too is prevented by estradiol treatment. I'm interested in whether behavior can perhaps mitigate some of these consequences of the loss of ovarian function, and exercise is a logical strategy to consider. So this is a study in animals again that looked at the effects of exercise in this model that we've been using. It's a little bit complicated, so let me walk you through this. We're looking at changes in visceral fat on the left side of this slide and changes in an index of insulin resistance on the right side. All of the solid bars are the sedentary animals. And then because we know that overectomy decreases spontaneous physical activity, this was programmed exercise. They put the animals on treadmills and actually forced them to exercise. So the hatched bars are the animals that were undergoing this exercise training. So if we just focus on the solid bars first, we see the same patterns as in the previous slide, where for both visceral adiposity and insulin resistance, overectomy makes both of those things worse. And estradiol treatment prevents that. But if we look at the effects of exercise, even in the absence of estrogen, just exercise alone is effective at making both of these parameters as good or better as sham-operated sedentary animals. And if we combine exercise with estradiol, the most favorable changes in these parameters were observed, suggesting that both estradiol and exercise may be effective in maintaining good health after menopause in women. In preparing for this talk, I was informed that the Hemophilia Foundation is very interested in the impact on bone of loss of estrogen. And this is a study, again, staying with animal models, that on the left side looked at bone volume as a total volume of the bone compartment. So that's actually looking at the matrix and mineral as a fraction of total area or volume. And then on the right side is the number of trabeculi in the cancellous part of the bone. So just walking through the left side of it, the first bar are sedentary animals. That's the referent group. The effect of ovarectomy is this profound decrease in bone mass or bone volume. And just as in previous slides, providing those animals with estradiol completely prevents, and in fact, even enhances the bone mass that's present. So this is in sedentary animals. And then if we look at the animals that were exposed to exercise, and this was ambulatory exercise, actually with putting a little weighted vest on these animals, so it's increased weight bearing, you see the same pattern of change where ovarectomy, even in exercise animals, has this profound loss of bone. So exercise does not protect against ovarectomy related bone loss. But in these animals, there is still a benefit of giving back estrogen. And much of the effects of estrogen specifically on bone are in the cancellous compartment. So you see the same patterns of change looking at the trabecular number. Those are the struts in the framework that creates trabecular bone. So there's definitely an impact of ovarectomy on bone mass and in humans risk for osteoporosis. So if we summarize the effects of ovarectomy, it's to decrease physical activity level, decrease resting energy expenditure. It does increase energy intake. I didn't show you any data to support that, but it does. And the increase in fat gain that occurs is primarily in the abdominal region. And that's a region that we associate with metabolic dysfunction or metabolic harm. So that metabolic dysfunction that we expect is observed in animals. And as that last slide showed, there is an accelerated rate of bone loss. And most of these, in fact, I think all of these in animals are effectively prevented by estradiol treatment. Some of them are also, most of them are also prevented by exercise, with the exception of that last bullet, the accelerated bone loss. But the real key point now is, sure, we've observed all these things in rodents, but what is the relevance to humans? So let's go on to the last part of the talk, and that's focused on the clinical evidence that we have, whether all of this very intriguing data captured in preclinical models has any translational relevance to humans. I thought I would start out by a study that I did not conduct, but this was conducted by colleagues down at the Pennington Biomedical Research Center, Jennifer Lovejoy, Steve Smith, and their colleagues. That was a prospective cohort study, an observational study, where they started with a group of women who were nearing the age of menopause and then followed them for 5 years through the menopause transition. And they essentially took snapshots rather than a video. So once a year, they would bring these women in and get a number of measurements to get an idea of what is happening across the menopause transition. And let me orient you to how these slides are presented. So the 0 year is when women had reached the classification of being postmenopausal. So that's 1 year absence of menses. And then that value was set at 100% as the referent value. And then the the measurements obtained in the years leading up to the menopause are expressed before that as a percentage of what that value is. And then the years that they were followed after becoming postmenopausal are reflected on the right side of these figures. I will tell you that not all women made it out through all of these measurements, so that when you get out to 1 and 2 years postmenopausal, there are fewer numbers of women in there, so the variability of the data is a little bit broader. So what this slide is showing you on the left side is the change in body weight. And expressing this in relative terms, we would conclude that over the 3 to 4 years leading up to becoming postmenopausal, women gained about 5% body weight. So for a 150-pound woman, this would be 6 to 7 pounds. On the right side is the relative body fat level measured by DEXA. That's the same test that we use to measure bone density. And very similar results in the 3 to 4 years leading up to the time of becoming postmenopausal, women gained about 5% body fat. So keep that in mind when I show you another slide. I think it's the next one. Despite those relatively small changes in level of body fat, when they looked at fat in the abdominal region, and they do this by doing a CT scan, a CAT scan of the abdomen, so we're looking at fat area here, you can see a much more dramatic increase in fat that's stored right under the skin, the kind that you can pinch, subcutaneous adipose or fat tissue. And here, the increase leading up to the menopause is more like 10 to 15%. But it's the fat that's stored inside, behind the abdominal wall, in the visceral region, that is the fat that seems to be more associated with metabolic harm. And in this area, there was even a more dramatic increase in adiposity, almost a 20% increase. And I'll say that what we've learned from studies like this observational study, we already knew this, that the menopause is not an event, but rather a process. And it starts several years before women get to the point where we can truly classify them as being postmenopausal. So these changes occur during these transition years. And I think we know a little bit less about what happens as they continue beyond that menopause transition. Now, this next slide gives some insight into what causes this increase in adiposity, at least on a system level mechanism. These women completed a diet history, a diet record, to give the investigators a sense of how much they were eating. And we know that people underestimate how much they eat when we ask them to do this, but I don't know that they underestimate more over time. So I think these data are still relevant to look at, because this says that from 4 years before becoming postmenopausal to the time they became postmenopausal, there was a decrease in how much food they reported eating, how much energy they were consuming. That decreased by 1/3, from 150% down to that 100% level. And keep in mind, a 1/3 decrease in how much they were eating was not effective in preventing an increase in body weight or an increase in body fat. So that is really, really remarkable. And part of the reason why this happens is because of the decrease in how much physical activity they're performing. I think this is the best evidence I'm aware of that the menopause is actually associated with a decline in physical activity, because it was measured objectively. They didn't just ask women how much they were moving, they actually put a device on them, asked them to wear it for a week out of each year. So they have an objective measure of how much movement occurred. And from 4 years before becoming postmenopausal to that index year, there was a 50% decrease in physical activity levels, which is very consistent with those data that I showed you in laboratory animals. Now, there are advantages and disadvantages of using these sort of prospective studies to get an insight into what happens with the menopause transition. It does capture individual changes in outcomes over this period of time. And it also minimizes the effects of selection bias. You know, we're following the same women. We're not comparing some premenopausal women with different postmenopausal women. So those are the advantages. But the disadvantages to this approach is that they don't isolate the effects of the menopause transition. Women are also aging over this period of time. So there are a lot of things going on. They're making many changes potentially in addition to just going through the menopause transition. So that's one major disadvantage. The other one is that just this type of experimental approach does not allow you to infer cause and effect. So we get interesting observational data, but we really can't isolate mechanisms. So the approach that we use in my lab is a more controlled approach. We use something called GnRH analogs. Those are gonadotropin releasing hormone analogs that suppress ovarian function to postmenopausal levels. So here are some advantages and disadvantages of using this approach. The main advantage is that it is a randomized, placebo-controlled experimental approach that does allow us to infer cause and effect. And depending on the model that you use, the one we use frequently is to use this gonadotropin releasing hormone agonist to suppress ovarian function in premenopausal women, and then add back either placebo treatment, so those women would look like typical postmenopausal women, or we add back transdermal estradiol as a way to isolate the actions of estradiol. So that's very powerful in terms of trying to identify the mechanistic actions of estrogens. The disadvantages to this approach is that it's much more acute than menopause. It happens if we use an antagonist in hours. If we use an agonist, it happens over weeks and then can be sustained for a few months. So this is much different than the transition that occurs over many years. The other disadvantage is that unlike menopause, which decreases ovarian hormones and increases gonadotropins, FSH and LH, this approach suppresses both of those. So there are some potential differences there. Let me share with you some of the results of studies using this GnRH agonist approach. This was a study in which we randomized 70 premenopausal women into 2 treatment arms. Everyone was treated with the GnRH agonist. We used Lupron or leuprolide acetate for this, monthly injections. And then they were randomized to get either estradiol patch that they wore continuously during this time or a placebo patch. I'm going to refer to this as the 2-group model. Physical activity or exercise level varied in both groups. So this is widely generalizable to both sedentary and active women. And if you just look at their age, weight, body mass index, fat mass, and fat-free mass or lean mass, our randomization was effective in creating 2 very similar groups. I'm also going to talk to you about what I'll refer to as the 4-group model. When I wrote the NIH grant that supported this work, I wanted to get some very preliminary evidence into whether exercise might be effective in preventing some of the consequences of suppressing ovarian function. And in this case, it was resistance exercise or weightlifting type of exercise. So in addition to being randomized to these two groups, women were also randomized to whether they did or did not exercise, with about 1/3 of the women in each group being randomized to exercise. You can look at the demographic characteristics, and again, they're very similar. I want to emphasize that this was an exploratory aim. We did not have power to test any specific hypotheses. So this was really intended to be hypothesis generating, not hypothesis testing. So keep that in mind as I present those data. Let's look at changes in fat-free mass first. And this is in the two-group approach. So we know that the loss or the suppression of ovarian function causes the loss of bone mass, but it actually causes a loss of total body lean tissue. Now we know estrogen is a hydrating hormone, or when you remove estrogen, there is a dehydration effect. And water is a huge component of lean mass. So this may just reflect changes in levels of total body water. But to get at whether that is the case, we also did CT scans of the mid-thigh and measured muscle cross-sectional area. And when we did this, we saw the same patterns of change where suppression of ovarian function causes a huge loss. And in both cases, at the total body level and at mid-thigh muscle level, estrogen completely prevented that loss. So we believe that these data demonstrate that the loss of total body lean mass in response to ovarian suppression really reflects a loss of muscle. If we look at our 4-group model data, looking at the women, so let me just orient you to this. The blue bars are placebo treated, so suppression of ovarian function. The red bars are add back of estradiol. And then the hatched bars for both of these are the women who are in the resistance exercise arm. We know that resistance exercise is good for increasing or maintaining muscle mass, one reason why we picked resistance exercise. So again, we didn't do statistical tests to compare these groups, but if I was going to use these data to generate hypotheses, I would hypothesize that exercise in the absence of estrogen is sufficient to prevent a loss of lean mass with ovarian suppression. Estrogen alone with no exercise is also effective to prevent this loss. But if we treat women with both estrogen and exercise, we get an additive effect. So this suggests that the mechanisms by which estrogen and exercise regulate muscle mass are different. You can get the benefits of both. And then if we look at the CT data, so now we're looking at muscle cross-sectional area, we see exactly the same pattern of change. So again, we view this as evidence that these changes that we see are truly reflective of changes in muscle mass. If we switch to looking at measures of adiposity, we were very surprised by this result. We expected that suppressing ovarian function would lead to a relatively large increase in total body fat mass, and that did not occur. I'll show you a slide down the line of just why we were so surprised by this. So tuck that away in your memory banks. But another surprising finding was that despite the fact that there was no change in total body fat mass, there were substantial changes in abdominal adiposity. So when we looked at subcutaneous adipose tissue area, it was increased by about 4 to 5% in the suppressed group, and this was prevented by estrogen. And when we looked at the visceral region, this was even more dramatic. There was an increase here of 12%, and again, prevented by estrogen. If we look at these data from our 4-group model perspective, this probably isn't surprising that it was the 2 exercise groups within each drug treatment arm that tended to lose fat mass. Again, not significant, although, this is 1/2 to 3/4 of a kilogram of fat. I think everybody would appreciate even that small amount of change. But we were surprised again by the CT data. Remember, in animals, I showed you that exercise was effective at preventing the increase in abdominal adiposity. And that is not what we observed from these pilot data. Again, no statistics, but for both the subcutaneous area and the visceral area, in the suppressed group, the blue bars here, there was no benefit, no apparent benefit of exercise to diminish the increase in subcutaneous adiposity, and actually no effect of exercise within the estrogen treated group. But you can see that both sedentary and exercised women who received estrogen had essentially no increase in visceral adiposity. So this is a potent estrogen effect, at least based on these preliminary data. Again, because of your interest in bone, I couldn't find my colored slide for this, so I pulled this out of our manuscript. These are changes in bone mineral density at the lumbar spine, the total hip, and then various regions of the proximal femur. And you can see that in the suppressed group, there were pretty dramatic decreases in bone mineral density over just a 5-month interval. And this had been observed in other studies using this model. And again, estrogen was effective at preventing those changes. In our 4-group model, if we focus on the black bars first, these are the suppressed groups, hatched bars, the exercise group. At least at the lumbar spine, there was no benefit of exercise to prevent this bone loss. At the areas of the hip, exercise seemed to be a little bit more effective based on these pilot data. But if we look at the hormone-treated groups, these are the gray bars, the women who got estrogen. The effects of estrogen are much more potent in humans than the effect of exercise. There's no apparent benefit of exercise in those estrogen-treated women. We in Colorado have the benefit of having a room calorimeter or metabolic chamber where we can actually, this is in our hospital, we can have our research participants spend 24 hours in this chamber so that we can measure bioenergetics, or how much energy they're expending. So in a subset of women in this study, we had them stay in the room overnight. These are the results from their baseline or pre-intervention visits, just to measure resting energy expenditure and total energy expenditure. And this shows you that the 2 groups, placebo and estrogen treated, were very comparable. Based on what was observed in animals, we suspected that the placebo-treated group would have a decrease in resting energy expenditure, and that is what we saw. This decrease of about 60 calories per day, if there were no compensatory behaviors, so if these women did not increase how much they exercised or decreased how much they ate, this magnitude of disruption in energy balance would equate into an increase in fat mass of about 1 pound every 10 weeks. And estrogen prevented that change. We also measured total energy expenditure. That actually decreased by almost 130 calories per day. And in this case, estrogen was not quite as effective in preventing that. So again, this is just a snapshot, 1 day in time. We really need to do more work to get a better picture of what's going on. We did assess physical activity the same way that they did in that observational study, by having women wear a device that measures physical activity objectively. So they wore it for 1 week out of every month they were in the trial. And you can see here that there was a difference between the 2 groups, with the estrogen-treated group having higher levels of moderate to vigorous physical activity than the suppressed group. Now, this is the slide I mentioned that I would be showing you about why we were so surprised with the lack of change in fat mass in this study. When I wrote the grant, all of these other bars, with the exception of this one, were papers that had been published, and we actually used this to estimate what the increase in fat should be. So these are all studies that use the GnRH agonist model for different weeks in duration. And you could see that the longer women were suppressed, the greater increase in fat mass they had. So we were expecting the increase to be 1 to 1.2 kilograms, and in fact, we saw nothing. Not quite sure why that happened, but I'm going to share with you another study that we completed more recently. This was 24 weeks of treatment, and now you can see we did generate the change in fat mass that we expected to see. So let me tell you a little bit about this study. No estrogen treatment in this group. These were all women who were nearing the age of menopause. So they were all over 40 years of age and still had to be premenopausal. So we went up to about 50 years of age, but each individual woman was still classified as premenopausal, not peri or postmenopausal. We had a group that we gave a placebo injection to, so it was just saline. They didn't know if they were getting that or the GnRH agonist. Another group that got the GnRH agonist alone, and then a group that was treated with the agonist and was asked to undergo endurance exercise training. So you can see the demographics of these three groups. If we look at changes in fat-free mass, the placebo group had essentially no change, which is what we would expect. But both of the groups that got the GnRH agonist had the decrease in lean mass or fat-free mass that we've observed previously. And endurance exercise really doesn't have a muscle building effect. So this was not that surprising, that endurance exercise was not effective in preventing the loss of muscle mass. If we look at changes in fat mass, the placebo-treated women were gaining fat over this time, but the suppressed women gained more than twice as much fat, over 1.5 kilograms over just 6 months. And this was prevented by endurance exercise. So they were able to increase their energy expenditure sufficiently to prevent that increase. And then if we look, we did not do CTs in this study, but we did look at trunk fat mass by DEXA, and we see a very similar pattern where this dramatic increase, in fact, much of the increase in the fat mass is located in central body regions. And exercise did not seem to be as effective at preventing fat accumulation in this region, which is consistent with our previous study. When we looked at changes in energy expenditure from our metabolic chamber, the placebo-treated group was pretty consistent over time, whereas the suppressed group had a decrease in energy expenditure as we had observed previously. And this was mitigated by doing endurance exercise. None of these changes were statistically significant because there was a lot of variability in these somewhat small groups. If we looked at resting energy expenditure alone, a small decrease in the placebo-treated women, a larger decrease, not statistically, just mathematically, in the suppressed group, and exercise did not seem to offset this, which is the same as we had observed in our previous study, even though I didn't show you those data. And if we looked at physical activity levels, when we compared the suppressed group to the placebo group, there definitely tended to be a decrease, not significant, and this seemed to be prevented when we programmed their exercise. So if we compare these two cohorts that we've observed, the first study versus the second study, first study was all premenopausal women, age 20 to 50. Their average age was 35. In the second cohort, we focused on women who were approaching menopause. Average age was 46. So that is one difference. And as I pointed out, we saw these very different effects on the changes in fat mass. where it was only this second cohort that we studied where we saw what we classified as the expected increase in fat mass actually occurred. We did not measure visceral fat area in the second cohort, but if we look at the changes in total and resting energy expenditure, they're actually very similar between the two studies. So when we look at the studies that we've conducted, the obvious question is whether age contributes to some of the differential changes that we've observed, and that we'll try to address in a future study. I wanted to bring out one more point as I wind up here, and that's that we have always focused, the vast majority of preclinical and clinical research in this area has focused on estradiol. But anytime estradiol goes down, follicle stimulating hormone goes up. I said always, that's not always true, but in the vast majority of cases, this reciprocal relationship is there. And if you treat with estrogen, FSH goes down. So this very intriguing study came out in Nature in 2017, showing that if mice were treated with an FSH antibody that blocked the actions of FSH, it was effective in reducing body fat levels or dramatically, or preventing the gain in response to ovarectomy. And I was actually contacted before this paper was published. A couple of months before it came out, I was contacted by the New England Journal to ask if I would write an opinion piece on the potential clinical implications of that study, because they expected it to get a lot of press, and it did. And I can tell you that we have not studied the metabolic actions of FSH in humans, so everything that I put in there was speculative. I think the evidence that we have to date points to estrogen being the primary mediator of all these responses that I've been sharing with you. FSH is unlikely to play a role, but we need to do the studies to determine that. And just to show you from that Nature paper how dramatic the effect of FSH, that FSH antibody was in animals, these are changes in total fat volume, subcutaneous fat volume, and visceral fat volume of the abdominal region in mice. The IgG group is the placebo group, and then the red bars are the antibody group. So you can see reductions in level of adiposity of 50 to 75% when FSH actions were blocked. So let me wrap things up here. If we consider the role of estrogens on body composition and fat patterning, both preclinical and clinical studies provide very consistent evidence that estrogens play an important role in regulating body composition. The loss of estrogen accelerates the loss of bone and muscle, and it promotes fat gain through multiple system-level mechanisms. It decreases resting metabolic rate, probably decreases how much people are moving or animals. And I didn't show you this data, but also tends to increase energy intake. It's likely that both the loss of ovarian function, menopause, and aging contribute to the changes in body composition. But our evidence at this point in time suggests that the shift in where women accumulate fat, hips and thighs before menopause, abdomen after menopause, is likely triggered by the loss of estrogen, not necessarily aging per se. And we don't know if this could be related to the increase in FSH, but we're studying that now. And in mice, both increased FSH and decreased estradiol promote fat gain, particularly in the abdominal region. We have to wait a few years before we have any evidence to determine whether this is true in humans. And I think if I take, the 30,000 foot perspective of everything I've shared with you today, I think it's likely that both the menopausal decline in sex hormones and aging increase the risk of age-related diseases. But I think the specific role of sex hormones, which we know increase the loss of those, increase the risk for osteoporosis, probably contributes to the increased risk for things like cardiovascular disease, hypertension, and type 2 diabetes. So with that, I just want to leave you with an acknowledgement of my colleagues who helped me in this work. We refer to our research group as the IMAGE group, Investigations in Metabolism, Aging, Gender, and Exercise, my funding sources, and then some of the important centers that I'm affiliated with at the University of Colorado. Thanks very much for your attention.
Good afternoon. We are very excited to be able to speak with you today about the work that our Working Group 4 has done for the State of the Science Summit. Our group is specifically dedicated to the population of women, girls, and persons who have or have had the potential to menstruate. My name is Dr. Angela Wyand. I'm a pediatric hematologist at the University of Michigan. I have a specific interest in bleeding and clotting disorders in young women and girls and people with the potential to menstruate, and have a clinic with pediatric and adolescent gynecology here, focus on that population. And I'm excited to be here today with my co-chair, Dr. Maureen Baldwin.
Hi, I'm Maureen Baldwin, an obstetrician and gynecologist in Portland, Oregon at OHSU. And I have a special interest in menstrual management for adolescents, but I am also a full scope OBGYN and manage birth frequently.
So I'm going to get us started with our presentation today with giving you all a little bit of background on why this specific population really needed its own working group. So when we started this working group and when the steering committee put together this working group, we really wanted to be as inclusive as possible and include cis women, cis girls, as well as the transgender community. So wanted to go with the overall title of Women and Girls and People Who Have or Have Had the Potential to Menstruate, as we would be covering topics ranging from menarche to menopause and everything in between. So this group has historically really been kind of ignored and underserved. There's estimated to be about 1.6 million individuals in the United States with a bleeding disorder within this population, but unfortunately a lot of these have misdiagnoses as well as delays in diagnoses. At least one study on von Willebrand's disease has noted a lag of up to 16 years between symptoms and diagnosis. Unfortunately, the bleeding in these individuals does have some pretty significant medical consequences, and they have pretty unique issues that change across the course of their lifespan. Unfortunately, I think that sexism contributes to this problem and gets us into a vicious cycle. Historically, menstruation has been really stigmatized, which has led to patients and providers alike being unaware of what constitutes a normal period. Further, they don't really discuss their periods with anyone and often may not even present to care. This underappreciation of what is a normal period leads to bleeding disorders being underrecognized as well as underdiagnosed. With that, all of the resources tend to be dedicated to men and disorders that affect men, which further perpetuates this vicious cycle. Within research, this is particularly a problem with a lot of the resources and funding going to disorders that predominantly affect men. A quick PubMed search for menstruation finds less than 4,000 publications per decade compared to around 15,000 for a similar search of semen. We see these disparities in other areas like cancer, where uterine cancer, ovarian cancer, and cervical cancer all receive a lot less funding than prostate cancer, even when adjusting for incidence and lethality of disease. Looking at all disorders in NIH funding, one study found that approximately 3/4 of funding decisions favor men in that they overfund disorders that affect men, regardless of how common those disorders may be. There have been some improvements within this area, as in 1990, the Office for Research in Women's Health was created at the NIH, and in 1993, they began to require that women were enrolled in studies. However, Up until 2019, women's health research was defined by the percentage of subjects enrolled, regardless of what the topic of the research was. So only in 2019 did this change, and women's health research began to be defined by the scientific relevance of the topic. So looking at bleeding disorders specifically, we know that hemophilia was first described in the early 1800s, and it was another 120 years before there was a report of a female with hemophilia. Even within this report, they describe really atrocious, awful symptoms, and then go on to comment that her symptoms and her presentation were much less severe than in typical or true hemophilia in men. Von Willebrand's disease, which has always been appreciated to affect both sexes, was described a few years later. Unfortunately, although we've known for many, many, many years that these disorders affect women, it wasn't until 2012 and 2018 that our large international federations actually changed the definition of hemophilia to include women. As I mentioned, there has been some movement in the right direction. So the National Hemophilia Foundation started in 1948. It was another 50 years before there was a specific task force devoted to women with bleeding disorders. 2 years later, Project Red Flag was started. This was a collaboration between the CDC and the NHF and was largely a public awareness campaign. 8 years later, there had been $500,000 in funding for this type of work. 75% of NHF affiliated chapters had dedicated programs for women, and the number of women seen at HTCs over this time course had increased by 200%, which is a pretty impressive number and definitely moving in the right direction. This progress has continued over the past decade. So in 2010, the National Hemophilia Foundation started what they termed as phase 2 with Victory for Women. This had 2 prongs that aimed to increase awareness of bleeding disorders, but also to provide support for women that were suffering or affected by these disorders. Further, in 2016, the Better You Know campaign was started to help identify undiagnosed bleeding disorders. These projects all have a lot of really great resources online, including downloadable menstrual charts where people can chart their menstrual periods. There are free postcards that you can send. There are online risk assessments that patients can take and other resources that are available. So as we have all heard, the National Hemophilia Foundation put together this summit in order to formulate a national research blueprint and to prioritize research questions based on their feasibility, risk, and impact. Specifically, Working Group 4, as I mentioned, was devoted to the specific population. And initially, the National Hemophilia Foundation conducted listening sessions throughout the community in order to try and find out what the community felt like was important in the national blueprint for research. Over these sessions, there were 98 participants over the course of 14 sessions, and a lot of them had bleeding disorders or were caregivers for patients with bleeding disorders. Additionally, there were healthcare professionals and leaders of organizations, as well as industry representatives. Across these, they found a number of themes that seemed to be applicable across many bleeding disorders, as well as some disorder-specific priorities. Within our group, the areas where they felt there were areas to focus on included gender, including LGBTQ, as well as specific research on women with bleeding disorders, such as novel therapeutics for von Willebrand's disease, the impact of symptoms and manifestations across the lifespan, joint disease in women, as well as hemophilia carriers. So we were tasked with prioritizing research questions for the health of women and girls and persons who have had or have the potential to menstruate. Some of the initial thoughts from the steering committee included novel therapies for bleeding, risks specific to women and girls within gene therapy, non-invasive prenatal diagnosis, sex and gender biology, hemarthrosis, and inclusion within clinical trials and data collection. We were further provided with an overall framework within which we could think about these issues and formulate questions. These were specifically divided up to look at multidisciplinary research that would be basic or more lab-based, as well as translational research that could be translating the findings within laboratory-based research into the clinical setting, as well as a separate category to look at multidisciplinary clinical studies and trials. As you can see, there are a lot of different areas that were highlighted as points of interest. As I mentioned, we were tasked with prioritizing these questions within a specific framework looking at risk, impact, and feasibility. So hypothetically, we would want questions to be feasible or able to be done easily, that would have great impact on the care of our and overall health of our patients, but that would be low risk in terms of both risk to patients, but also risk in terms of resources and funding needed to fund those projects, with the idea that we would want there to be good outcomes and data from those projects if we were investing in them. So we were really fortunate to be able to invite a number of really amazing national as well as international experts that we thought would be best situated to help us prioritize these types of research questions. We had representation on our working group from obstetrics and gynecology, from both adult and pediatric hematology, genetic counseling, transgender research, physical therapy, social work, nursing, industry, both contraceptive industry as well as factor-based, the patient perspective, as well as organizational partners. We were incredibly fortunate to have a lot of engagement with our group, and we've met many times over the course of the last several months to discuss these research areas and prioritize our questions. And we've been very grateful for all of the work that these individuals have contributed to our cause. We know that the National Hemophilia Foundation and this working group do not exist in a bubble, and that in order to really advance these causes and really be able to better the care and health of our patients, we will need a lot of collaboration. And luckily, there are a lot of organizations out there that are either currently doing or poised to do this type of research. So this is just kind of a smattering of some of the organizations that we think will be good to collaborate with going forward, that range from the federal funding mechanisms of the NIH, the CDC, as well as more nonprofit and private organizations. So with that, I thank you, and I'm going to turn it over to my amazing co-chair, Dr. Maureen Baldwin, to walk you through what we came up with.
Now, I'm going to provide an overview of the research priorities developed by our group after several brainstorming sessions. This was really a collaborative, iterative process, and the iterations keep going on. But after coming up with a long laundry list of research questions during brainstorming, we were able to categorize them into about 5 or 6 focus domains, including uterine physiology and bleeding, bone and joint health throughout the lifespan, sex and gender lifespan biology, including impact of both exogenous and endogenous gonadal steroids, and pregnancy and postpartum, which we separated out as a separate lifespan experience due to the impact of neonatal genetic diagnosis and the amount of impact of bleeding at the time of birth. And finally, healthcare delivery we identified as a separate domain because of the importance of screening access and diagnostic and treatment strategies through the healthcare delivery system. For each of these domains, we identified some mechanisms of disease, diagnostics and screening opportunities, therapeutics, where we might benefit from improvement in clinical trials and inclusion in clinical trials, patient-related outcomes and quality of life, which then became its own domain simply because we had very little knowledge of many specific categories in patient-related outcomes. And then finally, where we can benefit from advocacy and collaborations for each of these areas. The foundational research gaps that we identified from these domains include the following: understanding the norms and standards for hemostatic biomarkers for diagnosis and monitoring treatment, understanding the prevalence of phenotype or disease severity. For example, what are the factors that lead to more severe disease for specific individuals or for specific bleeding disorders? We also lack feasible methods to measure bleeding amount during menstruation, during procedures, within joints, and at birth. While we have a lot of methods to understand patient-reported bleeding and lots of very complicated methods to measure blood loss in a scientific level, we really lack feasible methods that can be disseminated easily. The high expense of the methods required by the FDA really holds us back on being able to do comparative trials. And then finally, we wanted to highlight that while a lot of excellent work has been done in the assessment of patient-centered outcomes, we lack a broad understanding of the most important domains that impact quality of life for this population, and particularly in the area of mental health. Because we are a really pragmatic group, most of the questions we came up with fell within a scoring range of moderate to high feasibility, high impact, and low risk. And feasibility concerns mainly were related to cost and not so much the ability to engage participants or researchers in that topic area. So we're presenting the question themes for each domain in these Venn diagrams to demonstrate the relationships between questions and the relative impact. In the domain of sex and gender lifespan biology, we mentioned that we lack the understanding of hemostatic factor levels, parameters, reference ranges for diagnosis, and understanding the impact of different therapies on those levels, understanding pharmacodynamics and pharmacokinetics in our population as well, which is really key to understanding the severity of bleeding disorder, phenotypes, or experience of the bleeding disorder. We wanted to highlight that there are impacts of gonadal steroid hormones on those levels, on phenotype levels. There is a genotype impact on levels as well as on the experience of bleeding disorder that we don't fully understand in our population. That we don't understand the impact of comorbidities. And then where we can benefit from knowledge about aging and the pubertal transition and aging and the menopausal transition related to all of these questions. These questions tended to be higher cost due to all the laboratory analyses and therefore had scoring that were lower on the feasibility scales. And they were also high downstream impact because of the ability to run clinical trials about effective therapeutics require some of the knowledge of these levels. So in the domain of patient-reported outcomes and quality of life, we really centered on mental health impact as a key question. And then for all the separate areas that affect our population, not exclusively, but really impactfully, we felt we really lacked some quality research. So why do patients make reproductive choices in the setting of a bleeding disorder? How does that impact sexual health? How does that impact gender identity? How do menstrual bleeding patterns affect all of those things? What is the correlation between symptoms such as heavy menstrual bleeding and pain? And then the impact of that on healthcare utilization and health behaviors, including recreational engagement, attaining educational and vocational goals, and then family and relationships, and how does having an inherited bleeding disorder as a person who is a woman or a girl or has a uterus or had a uterus and the potential to menstruate, how does that impact parenting experiences, particularly when your family may be impacted by several members with an inherited bleeding disorder? We felt like these questions were high feasibility, but moderate to high impact, and that they may carry some risk, particularly when participants may not want to engage in answering the questions, and it might have an impact on their health outcomes to identify that this is a big problem. Related to pregnancy and postpartum, the key question became disseminating feasible methods of blood loss quantitation so that we can both institute research trials about feasible and effective methods for prevention of hemorrhage, as well as to understand hemostasis mechanisms, to understand bleeding disorder workup and who should be eligible or who should be screened for workup, how to identify whether there is a problem at the time of birth, we felt was really key. And that goes to being able to help with diagnosis of neonates, as well as understanding who really should be screened for prenatal diagnosis. And this led us to more questions about the coordination and in collaboration with family planning for preconception evaluation for prenatal diagnosis and genetic screening. We felt like there were some risk concerns in this area because of the impact of simply doing studies during pregnancy, but that there was higher cost occasionally, and that would be lower feasibility. And there was high downstream impact to doing this type of research. And this is similar to other research during pregnancy in other areas. For uterine bleeding and understanding uterine hemostasis mechanisms, again, blood loss quantitation kept floating to the top. And this really was key in our understanding of the relative effectiveness and dosing of different therapies. Some of the questions in here that were going to really challenge methodology and may be less feasible were thinking of uterine hemostasis mechanisms and how can histopathologic diagnosis strategies of the endometrium help with diagnosis and understanding treatment outcomes for potentially more novel therapeutics such as endometrial drug delivery. We wanted to understand hormone therapy impact on symptom workup and understand the drug interactions and outcomes with combined therapies, including hormonal therapies and antifibrinolytic therapies, for example. Additionally, we felt like there were several questions related to procedure safety and effectiveness for uterine procedures that fell into this domain. We thought these questions were also higher cost and potentially lower feasibility, although this was really variable throughout the questions in this domain, and that they were super high impact and were relatively low risk, very similar to the other domains. In the area of bone and joint health, which was a meaty topic, but we really narrowed it down to really a solid set of key questions, was mainly related to just understanding what is the prevalence in our population and why this may be different from what men experience, maybe due to biomechanical differences based on sex and gender, finding out what are the affected joints and how do we assess them. What is the role of gonadal steroid hormones, both endogenous and exogenous, throughout the lifespan on both joints and bone density? And what is the collagen impact on phenotype? These were really high feasibility questions with really uncertain impact depending on outcomes and low risk. In healthcare delivery, screening and referral became the most important because it's such a huge gap in our knowledge of what is the impact on our population. Screening tools are out there, but they're not entirely developed for each of the stages and phases of the lifespan, and need to be a little bit more clarified for different ages. This relates to questions about how do we know who's impacted the most on time to diagnosis? What are the characteristics of patients who have later diagnosis, for example? What are the costs to the healthcare system of putting all our money into screening versus into high-level treatment, for example? And how can we improve interdisciplinary integration for both picking up new cases and facilitating referral processes? How can we aid transitions? And what are the best care models for treatment? We thought these were varying feasibility depending on the level of engagement of the healthcare system within the research process, but high impact on improving outcomes for patients. And we thought they were low risk to patients and probably low risk to institutions, though they might not recognize it immediately. In conclusion, our framework of identifying these key research gaps of understanding the norms and standards, understanding the phenotype prevalence throughout the lifespan of how inherited bleeding disorders impact our population, understanding ways and methods of both measuring bleeding as well as disseminating those measurement strategies, and identifying patient-centered outcomes that are the most important. We felt these were the questions that should be focused on first and are really the foundation for the further questions that we identified. We would love to thank all of the participants in our group, as well as the National Hemophilia Foundation for creating this process, which felt like we were able to give equal voices from a lot of different fields. And here's a list of our participants who contributed. Thank you also to patients and the bleeding disorders community for pushing the charge for this population, which has had really low attention over the years. And we'll open it up now for discussion. Thank you.